In severe epilepsies, the aim will be different. My aim will be just to minimize seizure frequency with the best tolerable side effects, or the least side effects that's tolerable, and the epilepsy and its treatment will interfere as little as possible with the development of the infant or the child. Now, shortly, I'll describe the algorithm for some syndromes of epilepsy. In idiopathic generalized epilepsies, valproate is the most commonly used drug in the treatment in the primary generalized epilepsies, plus some of the new medications like levetiracetam. In benign neonatal convulsions, for example, usually it needs monotherapy like phenobarbital with add-on medication like clonazepam or carbamazepine. Remission of seizures is usually by the age of 1 to 6 months, and the prognosis for psychomotor development is very good. In benign myoclonic epilepsy of infancy, valproate monotherapy is usually effective, but ethosuximide is an alternative, and this is mentioned by Eckarty. And if myoclonias are not completely controlled by valproate, a benzodiazepine could help, like clonazepam. Childhood absence epilepsy, or the old name is the pituitary epilepsy. To start with, ethosuximide or valproate suppress absence seizures in more than 80% of cases. But some cases are resistant to ethosuximide or valproate, so the alternative will be lamotrigine. In juvenile absence epilepsy, valproate is a drug of choice because valproate controls both absence and generalized tonic-clonic seizures that is present in juvenile absence epilepsy. Topiramate or lamotrigine are alternatives. Some drugs to be avoided completely in juvenile absence epilepsy, which are carbamazepine, gabapentin, and vigabatrin. Juvenile myoclonic epilepsy, which is Jan's syndrome, in which there is a myoclonic seizures with generalized tonic-clonic seizures in 90% of cases, and only in around 30% of cases there is absence seizures. The drug of choice is valproate. Topiramate is a possible alternative. Avoid completely lamotrigine, carbamazepine, and gabapentin. In early infantile epileptic encephalopathy, which is the Ohtahara syndrome, we use broad-spectrum anti-epileptic like valproate, benzodiazepines add-on. Avoid phenobarbital, phenytoin, vigabatrin, carbamazepine. You may use corticosteroids or ACTH. In early myoclonic encephalopathy, also valproate is first choice, but take care that valproate is toxic to the liver in the first year of life, especially if you suspect a metabolic disorder like carnitine deficiency or mitochondrial disorder. So before initiating valproate, you have to do all the metabolic workup to rule out that there is some sort of carnitine deficiency. And if it's okay, supply or supplement valproate therapy with carnitine therapy. In early myoclonic encephalopathy, steroid or ACTH are indicated in some cases, and also avoid phenobarbital, phenytoin, vigabatrin, and carbamazepine. West syndrome, which there is in the infantile spasm, West syndrome classically improves with either vigabatrin or ACTH. Vigabatrin is used in Europe mainly, but in USA and Canada there is some precautions because of the visual field effect. It causes concentric narrowing in the visual field, like tubular vision. I think it is from 7 to 10% this complication, so they don't use it, but they go to the ACTH. Vigabatrin is a drug of choice in cases of epilepsy or infantile spasm with tuberous sclerosis. In West syndrome, other drugs may be used, pyridoxine, of course, vigabatrin in Europe, as I mentioned, topiramate, benzodiazepines, and valproate. We have to avoid in West syndrome carbamazepine, phenobarbital, and lamotrigine because they aggravate the spasms. The protocol for steroids is ACTH 20 to 30 units per day for 4 weeks, then taper over 2 weeks. Alternative for ACTH is not available now, I think, so the alternative will be prednisolone, 2 mg per kg per day for 4 weeks and to be tapered over 2 weeks. The protocol for vigabatrin is to begin with vigabatrin 50 mg per kg per day to increase by 50 mg per kg per day every 3 days to reach 150 mg per kg per day. The endpoint for ACTH or vigabatrin is 2 things: to achieve improvement in the hypsarrhythmia of the EEG, number 2, cessation of the epileptic spasm. And this is the endpoint for the increments or for the increase of the drugs, and we have to taper at this point of hypsarrhythmia. Hypsarrhythmia also will improve, but it will be epileptogenic with spikes or multifocalities or something, some severe epileptogenic activity. But the hypsarrhythmic pattern should be changed to another form, and the epileptic spasm should stop. Lennox-Gastaut syndrome, useful combination is valproate and benzodiazepine. Other drugs used include levetiracetam, lamotrigine, or topiramate, or zonisamide. Steroids may tide the patient over bad periods, and usually, the Lennox-Gastaut syndrome is characterized by bad periods and remissions. In the bad periods, there is exaggeration of the seizure frequency, and we can use a steroid in this period. After that, we can use the usual seizure medications like levetiracetam, topiramate, lamotrigine. We have to avoid also carbamazepine, phenobarbital, and vigabatrin. Some surgeries could be useful in Lennox-Gastaut, like corpus callosotomy, or if there is cortical dysplasia, we can do the cortectomy. In DUS syndrome or myoclonic astatic epilepsy, we can use myoclonic astatic epilepsy. There is drop attacks, and usually this syndrome was looked at the past as being benign, but now we have some developmental regression in these cases of DUS syndrome or myoclonic astatic epilepsy. The drugs of choice: valproate, ethosuximide, clobazam. Another useful combination is valproate with lamotrigine, but we have to avoid carbamazepine, phenytoin, phenobarbital, and vigabatrin. Myoclonic absence epilepsy, the combined use of valproate and ethosuximide is the first choice. Topiramate, lamotrigine, or clonazepam also may be added, but we have to avoid carbamazepine, phenytoin, phenobarbital, gabapentin, and vigabatrin. Lastly, I would like to mention the neonatal seizures. Phenobarbital is the first choice drug. If there is resistance to phenobarbital, we can add on levetiracetam. Also, if there is resistance, we can try IV 50 to 100 mg pyridoxine. Other drugs to be added: benzodiazepines, but take care of the apnea; valproate, but take care of the hepatotoxicity; and phenytoin, but take care of the nonlinear pharmacokinetics. Severe myoclonic epilepsy or infancy, which is a Dravet syndrome. Valproate is the initial drug of choice. Clobazam or clonazepam added after the first prolonged or repeated seizures. Ethosuximide, topiramate, levetiracetam, stiribintol may also be used, but we have to avoid carbamazepine, phenobarbital, phenytoin, vigabatrin, and lamotrigine. Now, to end with, I would like to have some guides on anti-epileptic drug therapy. Therapy should always begin with a single drug, even in children with more than one seizure type. Monotherapy is the best in all situations, as it is effective in most patients, and we have to avoid undesirable drug interactions and altered pharmacokinetics, and it improves the patient compliance instead of many medications. The anti-epileptic drug of choice. It is the most efficient against certain type of seizure. For example, in focal seizures, the best are carbamazepine or oxcarbazepine. The generalized seizures, best valproate. In absence seizure, ethosuximide, valproate. In myoclonic aesthetic or drop attacks, lamotrigine is the best, and so on. So, the target the efficient drug towards the certain type of seizure. The least side effect, a drug with the least side effect, ease of use, I mean once daily preparations or twice daily are better than thrice daily preparations. Broad spectrum anti-epileptic and least cost. So again, the anti-epileptic drug of choice is the most efficient, least side effects, ease of use, broad spectrum, and least cost. Golden rule is start low and go slow. I mean start with the least if possible dose. The least possible dose. Start with a low dose and then titrate gradually to reach the least dose that produce good therapeutic effect and to avoid the side effects of the medications. Titrate the dose to achieve adequate blood levels of the seizure medication. With those seizure medications that are measurable in the blood, like the valproate, like carbamazepine, phenytoin, phenobarbital, ethosuximide, usually titrate your medication to reach a therapeutic blood level and take care of measuring the peak and the trough levels. It's very important to have or not to have a difference between the peak and the trough more than 50%. And this is mostly pronounced in carbamazepine therapy, because carbamazepine, after the use of 2 or 3 months, it has a phenomena of autoinduction. It induces its own metabolism in the liver. And so there will be fluctuation of the blood level of carbamazepine during the day after its use by few months because of this autoinduction process. And if this phenomena, it happens in like 30% of children. If it happens, it will prohibit its use because this fluctuation will cause breakthrough seizures. So if you measure the peak and the trough, difference more than 50%, you have to reconsider the dosing of the medication or to change to another one. Then the steady state is reached at 5 half-lives after the last dosage increment. And this is important when to measure the peak and the trough levels of the drug after 5 half-lives. Dividing dosages can minimize side effects. So twice daily or thrice daily may be important in some medications to minimize its side effects. If the first drug used is ineffective, then a second drug should be added with a clear plan of weaning the first drug. If the child is still having seizures, review the patient compliance. It's very important to have a seizure diary and medication diary. So you will monitor your patient if he is having the medications regularly, promptly, or not. And this may be cause of intractability. It's not the epilepsy, it is the patient compliance. What are the indications to obtain serum anti-epileptic drug levels at initiation of therapy, to determine compliance of the patient, to diagnose dose-related toxicity, to determine the effects of anti-epileptic drug interactions, and in all uncontrolled patients we have to do blood levels. If the child is well controlled but levels are subtherapeutic, it is not essential to increase the dose. And if a drug is above therapeutic level with no appreciable side effects, it does not have to be reduced. If the child is rapidly growing, we have to adjust the dose frequently on a weight basis, and this is important. And any patient with uncontrolled seizures on anti-epileptic drug polytherapy, more than one drug, he should be assessed for a slow transfer to monotherapy. Don't leave your patients on polytherapy on more than one drug for a long time. After you achieve seizure control, always your aim is to reduce the medication to the least number of drugs. Any patient entering remission should, number one, be counseled on the risk factors for relapse and to continue on anti-epileptic medications for a 2-year period of remission as a minimum. I said as a minimum because in some cases of epilepsies with a cause, symptomatic epilepsies, the duration of therapy could be prolonged, yes, more than 2 or 3 years, because we know that there is high incidence of relapse. Anti-epileptic drugs should never be withdrawn abruptly. It usually withdraw over a period of 2 or 3 months, and the drug that needs long period of withdrawal is benzodiazepines. Clonazepam needs a long time for withdrawal. Lamotrigine, it's very important, worsens myoclonus and the severe myoclonic epilepsy of infancy. Vigabatrin worsens some forms of myoclonic seizures and absence. Carbamazepine and phenobarbital worsens infantile spasms, absence, and myoclonic epilepsy. Anti-epileptic drugs that can be given once daily are phenytoin, phenobarbital, clobazam, clonazepam, vigabatrin, and lamotrigine. All of these can be given once daily. And I think this dose is enough for this night. Thank you for all who watched this video, and thank you for Rabta Dumyat, Dr. Bassem Shams, Dr. Osman El-Shwaihi, and all the colleagues in Dumyat, and I enjoy very much being on this Rabta, and for inshallah future videos. Thank you very much. Good night.